So just going back, CUMARS is an acronym for Custom-Made Articulating Spacer. Okay. So we talked about the ideal cement spacer being cost-effective. It needs to be easy to insert and remove. Stability is a big issue, especially in hips. It needs to allow weight bearing, allow flexibility of antibiotics, and allow local antibiotic delivery. Okay. Multiple types of spacers. So we've heard from Dr. Dave about this. So static and dynamic. And within dynamic, there is a range. So you have the handmade hemiarthroplasty, so hand molded in terms of the stage 1 select from Biomet, or you have the preformed ones, the Prostalac, and then the hybrid articulation, and finally the CUMARS. Okay. So molded spacers, obvious advantages. The molds are, it's handmade, so easy to do, flexible antibiotics, and you can custom it to the available space. However, it is time consuming, especially if you're the solitary surgeon, then that adds to the surgical time. Usually patients need to be non-weight bearing, as rarely it has a metal core. The cement delivery, because you're mixing it by hand, even though it's vacuum mixing, it's inconsistent than factory made ones. And fractures and dislocations are quite common. The preformed spacers, we saw some of the antibiotic delivery is much more reliable because it is sort of mixed in factory. The fracture risk is low because by and far they have a metal core, the operative time is less, and partial weight bearing can be permitted on this. But the problem is they can be costly. The antibiotic profile is fixed, so there's no flexibility in what antibiotics you can add. Obviously, you can add the antibiotic that you use to fix it. And implantation can be difficult. Because of the metal core, they tend to be quite bulky. Okay? So it's very hard to get them in. That's where the CUMARS comes in. So this was initially described, or sort of, there is a story to it about the fellows being Australian or Kiwi, called the Kiwi procedure in 2001. And what they used was an Exeter stem and polyethylene liner, described in Exeter. It's universally available, and that was the attractive. As has been mentioned before, this was not a new concept, but utilization of an old concept where Hoffman had done it with autoclave prosthesis for total knee replacements. Okay. So the femoral prosthesis was then cleaned, autoclaved, and reimplanted with a new all polyethylene liner. And they had no reinfections in about 26 patients. So it was not a new technique. But then this was, Jason Sung was the sort of Australian fellow in Exeter, and they described 76 cases of using the CUMARS technique. And there were two versions of this. The original CUMARS technique was when they coated it with cement and inserted it early, and just before it started going, took the prosthesis out, okay, let the cement settle, and then put it back in. And what they found in those patients is that they had a lot of pain afterwards. And so they modified the technique so that now they insert it and leave it in. So that step was cut out. So of those 76 patients, 34 patients had that CUMARS retained, which was the attractive thing. So they never got to the reimplantation stage. So it gives better joint function in the pre-reimplantation period. So obviously it's a strategy for sort of two-stage revision. The better stage, interstage functionality. Okay, so lots of studies on that they function much better. The removal is fairly easy. It gives you excellent infection control. And occasionally it can be the long-term approach. I think there are varying thought processes about this. So if you're fixing it badly, is it a sort of a full hip replacement? Why would you not go in if the patient was fit enough to change it, or the patient may not want it? So that's what is sort of discussed as a 1.5 stage exchange arthroplasty. So this is a CUMARS done in our unit, and I think if a registrar did that cemented hip, I would be very disappointed. Okay, so, but it's easy to remove. So we have this, what we call a back scratcher. So you can just drill it distally and then use the back scratcher to go through, and the whole thing can come out in one go. You can extend the concept. Okay, so if you're doing resection, so this is a case from an infected hip that we had to take out, and we had to resect the proximal femur. So this is a nail, and you've built sort of going through a 60 ml syringe, make the femoral body with cement, and then use one of the trials to coat the femoral head with a glove in so that you manufacture the head. And the offset is customizable. So you can lock the screw wherever you want, and that will give you the offset. So effectively, the CUMARS, it's a costly option because the Exeter stem is costly. I mean, in the UK, in certainly our unit, it costs about £300. So it is not cheap. The cup is a lot cheaper. Dislocations can be common. Bone loss is a blessing on the acetabular side, but on the femoral side, it can be a problem. Fractures can occur distal to it. Biofilm formation remains a concern, and inconsistent antibiotic delivery is an issue. So if you think about spacer comparison, this is Kugelman's work. So what they compared is this real component, as it's called, RC spacers, compared with all cement spacers. And they did not really find any difference in reinfection or reoperation rates, but this was not statistically significant, but the real component spacers had less length discrepancy after reimplantation. There was less bone loss, less blood loss, and shorter length of stay. This then was extended to having long stem CUMARS. Okay? So 205 lengths, so where there is femoral bone loss, Quayle reported on 21 patients with about a 4-year follow-up. Okay? And all the stems were in excess of 205 millimeters. So they had to bypass the proximal femoral bone loss, of which 5 remained in situ, and only 12 patients, they did the second stage. So in 9 patients, 5 patients, it remained in situ and they didn't have to do any more operations. Imagine taking that long column of cement out if it did not come out easily. If you looked at the current evidence, so this was a systematic review of 45 studies using now not just CUMARS, but static versus dynamic spacers. And as has been described today, so the static spacers, the main issues are mechanical complications. With the dynamic spacers, instability is a bit of an issue. However, in both scenarios, you get high rates of eradication of infection. So there's no concern whether you use a static or a dynamic. Dynamic will remain better for function. There are some future options, so 3D printed assisted spacers, so that can conforming geometry. Also, you can use polylactic acid, which is, again, you don't then restrict your choice of antibiotics. But this is all in the trial stages. This is just a comparison of all the spacers, and you can see with the temporary joint prosthesis, you get excellent mechanical performance, decent pharmacological performance because it's hand mixed. Stability and cost depends on what implant you use. And then it's a metal and polyethylene articulation, so there is a chance of biofilm formation again. So if you think of the first slide about the ideal spacer, this ticks most of the boxes. It's easy to insert and remove, stability is good, weight bearing is always possible because these are real components. Local antibiotic delivery and flexibility of antibiotics is a given. The cost-effective bit is the only bit that's contentious. So it's a good option, especially on the acetabular side. On the acetabular side, if you've got big bone loss, you can't really put a hemiarthroplasty spacer. Whereas what you can put is a big dollop of cement in there and cement, a sort of cheap cemented cup in there, and it will give you decent function. Infection control rates are similar. It gives you the potential for a 1.5 stage revision. Bone loss and cost remains a concern. In our unit, certainly, we are increasingly using the CUMARS, and it's a spacer of choice on the acetabular side if there is bone loss. Thank you very much.